So we're going to move on to Dr. Ramirez. It's my pleasure to introduce Dr. Faustine Ramirez. She is an assistant professor of pediatric orthopedics here at UCSF. She's a primary care sports medicine provider. She completed her medical school training and pediatric residency training here at UCSF and did her sports medicine fellowship at Stanford. She has special interests in musculoskeletal ultrasound and the care of adolescent female athletes. She was an accomplished collegiate athlete herself, so quite fitting. And she's going to talk to us today on the indications for ultrasound-guided hip injections. Welcome.
Let's get you out of here. That should be you. You're all set.
Okay, great, thanks. Thanks, Dr. Watkins. I'm really excited to be speaking with all of you about this topic. So I have no disclosures. We're going to start off with a case today. So 16-year-old high-level ballet dancer presents to clinic with insidious onset of anterolateral right hip pain for 6 months that is exacerbated by hip flexion. She also complains of the hip occasionally feeling stuck. She has been modifying her dance activities due to the pain. She has been doing physical therapy for 2 months with minimal improvement, but her pain has been hindering her progress in physical therapy. Her exam is notable for pain with hip flexion and internal rotation and a positive fader and scour test. So what is the best next step? A, MRI to rule out a femoral neck stress fracture. B, MRI to evaluate for a labral tear. C, continue physical therapy and activity modifications. D, consider an intra-articular hip injection. And E, all of the above. So I'd like you to take a minute, chat with your neighbor, and see what you think the best next step would be for this patient. I'll give you a second. Okay, I'm hearing a lot of great discussion, which is awesome. So the correct answer here is E, all of the above. And we'll go over some of these very briefly. In this patient who is a high-level ballet dancer with a lot of hours of activity per week, you should absolutely be worried about a femoral neck stress fracture and any stress or bone stress injury. Her exam does point more towards a labral injury, but the exam maneuvers are not the most specific, and with any type of intra-articular hip pain, you could get pain with all of those maneuvers. So you absolutely should be thinking about a femoral neck stress fracture. You should also be worried about a labral tear. You're going to be hearing a lot more about that from different speakers. We'll go over that injury in a little bit more detail further along in the presentation, but some of her findings are concerning for a labral tear. Because we're more worried about a labral tear than a stress injury, it would be appropriate to continue physical therapy and activity modifications, but if you were more worried about a femoral neck stress fracture, then you would shut her down completely. And then you would also consider a hip injection in this patient. So let's talk a little bit more about that. So case continued, MRI is obtained, which confirms she has a labral tear. Due to inadequate improvement after 2 months of physical therapy, she is referred to a hip surgeon who recommends arthroscopic labral repair. However, she has very important rehearsals that are coming up and several big performances in the coming months. So she would like to postpone surgery until she has a break in her dance schedule. So which of the following is a potential indication for hip injection in this patient? A, to confirm her pain is truly originating from the labral tear. B, due to inadequate response to physical therapy. C, to maximize non-operative management before considering surgery. D, to improve her pain so she can make progress in physical therapy. and E, to improve her pain so she can finish her performance season, or F, all of the above. So again, take a moment to, chat with your neighbor, never mind. But we're gonna go through all of these. These are all appropriate indications, and you may have guessed that I tend to go with all of the above. So let's go through and talk a little bit more about each of these throughout the presentation. So to give you a big overview of the types of hip injections we'll be talking about today, we'll be focusing on intra-articular hip injections, iliopsoas bursa and peritendinous injections, and greater trochanteric bursa or gluteus medius peritendinous injections. There are other types of hip injections. I would say these are the most common ones that we typically consider, although there are a few other more specialized types of injections. But of all of these, the ones that we'll be talking about the most today are the intra-articular hip injections. So we'll go through each of these and some of the more common clinical indications. So starting with intra-articular hip injections, so this diagram here demonstrates the different types of injections we'll be discussing, and the letter D corresponds to an intra-articular hip injection. So this gives you a sense of the anatomy here. And the picture to the right is an ultrasound image of what the injection would look like. So just to orient you, the A is the acetabulum, the H is the femoral head, and the N is the femoral neck. And you see, I don't know, can you see my pointer here? This bright line overlying the femoral head and neck is the hip capsule. And then you have a lot of musculature overlying the hip joint, notably the iliopsoas muscle here. And the arrow indicates the direction of the needle. So the ultrasound probe would be oriented in a slightly oblique orientation here, and you position it over the femoral head and neck, and you aim for the head-neck junction. And the goal is to inject the medication underneath, you get into the hip capsule at the head-neck junction. So that's the injection target. This is the most common approach for ultrasound-guided intra-articular hip injections. And you may be feeling like this is very close to the very important neurovascular bundle. It's a little bit lateral to that, so it's we can use different tools on ultrasound to make sure that we're avoiding important vessels, and we can visualize the vessels and the neurovascular bundle with ultrasound, and that's something we certainly do before injecting when we're getting our landmarks. But you can see it's actually a little bit more lateral here where we're injecting, and so there's no nerves or vessels in my field of view here, and I can use the ultrasound tools to avoid those. So what are some of the common indications for intra-articular hip injections? So one of the most common ones is femoroacetabular impingement, and we'll be hearing a lot about that today. A labral tear is also a common indication for an intra-articular hip injection. Less common would be hip dysplasia on the mild or borderline side. I don't want you to leave this talk thinking we treat hip dysplasia with injections. Legitimate hip dysplasia, we've talked a lot about the different treatment options, but if it's a case in an older patient that's on the milder side or more borderline side, or even in the setting of hip microinstability, we sometimes do consider intra-articular hip injections as part of either the diagnostic or the therapeutic interventions, as well as in juvenile idiopathic arthritis, not something that I typically treat in sports medicine, but in rheumatology, our rheumatology colleagues sometimes do treat JIA with injections with potent corticosteroid anti-inflammatories. So we're going to touch a little bit more detail on the first two, which are the more common indications for these injections. And you'll hear a lot about these, so this is going to be more of a big picture overview. But I do want you to know what we're talking about here and have a sense of these different conditions. So FAI, or femoroacetabular impingement, typically presents with gradual onset of anterior hip and groin pain in a C-shaped band around the hip, typically worse with prolonged sitting, often positional and activity related. It may be associated with a labral tear, but not necessarily. And on exam, you may see limited flexion and or limited internal rotation, as well as pain with those maneuvers, a positive fader and scour test. And we'll be going over these exam maneuvers a little bit later this morning in the hip workshop with Dr. Wong and I. So if you're interested in learning more about these, would love to join you there. So workup typically includes X-ray and MRI, You may start with an X-ray, and if the patient's not responding to conservative management, pursue an MRI. And treatment conservatively typically starts with physical therapy, NSAIDs, either as needed or a short course of anti-inflammatories, rest or activity modifications depending on the patient's activity level, potentially injections, and arthroscopic surgery, and you'll be hearing more about that next with Dr. Wong. So when would we consider injections for these patients? So if they've had an inadequate response to physical therapy, so typically I recommend at least 6 to 8 weeks, if not a little bit longer, before considering injections. So even up, 8 to 12 weeks of regular physical therapy, and really important to make sure that the patient is not just going to the sessions, doing the exercises regularly on their own, that they've been adherent, that they're not just showing up for physical therapy once a week, because that's not typically going to be enough. Sometimes patients have too much pain to even do the physical therapy. So if they have too much pain that's limiting their progress, that could be another reason why you consider a hip injection. Often we pursue diagnostic injections for FAI or for labral tears, which we'll talk about next. So anterior hip pain can be quite complex, and it can sometimes be difficult to distinguish between intra-articular and extra-articular causes of anterior hip pain, such as iliopsoas, tendinitis, or bursitis. So injections can be very helpful in that setting. Sometimes we only use anesthetic, or sometimes we use a combination of anesthetic and therapeutic medicines, which we'll talk about a little bit later. But in that setting, if you're doing it for diagnostic purposes, we would typically do a physical exam and try to provoke their pain with provocative testing, ask for a pain score, and then after the injection, I would typically repeat those same maneuvers and ask for their pain score afterwards. And then I'm looking for some improvement in their pain scores after the injection. And we would expect to see pretty immediate improvement with the anesthetic medicines that we're using. They have pretty short onset of action. So I typically look for at least 50% improvement in their pain scores. Surgeons may have different thresholds, but that's generally a positive response if they're seeing more than 50% improvement in their pain scores. And often this can be helpful for surgeons who are considering surgery to treat FAI or a labral tear, to really confirm that the pain truly is coming from the hip joint, from the labrum, or from FAI, because hip pain can be complex, and before proceeding with a big surgery, especially in a younger patient, it can be really important to confirm. And then sometimes patients, realize that they may need surgery to treat their condition, but it's not a good time for them, either because they are, in school and want to wait for the summer, or want to be home from college. They're in their seasons and they want to wait until a better time. And so in higher level athletes or performers, I often will consider injections to help manage their timelines with their different sports. So if they, like the ballet dancer in the case, have a lot of rehearsals and performances and just want to get to the end of their performance season or to their sports season to a time that's more convenient for them, sometimes we can use injections in that setting. So again, athletes in season, if often have variations in their seasons, and so for timing purposes. So those are some of the reasons I might consider an injection in FAI. And labral tears, very similarly, are often going to be seen in the setting of FAI or in the setting of hip dysplasia. Will also present with either acute or gradual onset of anterior hip or groin pain. Often is activity related, and they may have mechanical symptoms such as locking or catching, or a feeling of the hip feeling stuck, as the patient did in this case. And on exam, they'll typically have pain with hip flexion and or internal rotation, and they may also have a positive Fader and Scour test. Workup would also typically include X-ray and MRI. And treatment is very similar to FAI with physical therapy, NSAIDs, rest or activity modifications, injections, and arthroscopic surgery. And I would consider the same indications here for a labral tear for injections. So either inadequate response to physical therapy, too much pain to pursue physical therapy for diagnostic purposes, or to delay or postpone surgery, or an athlete in season. So the next injection that we'll be talking about is iliopsoas bursa or iliopsoas peritendinous injection. So on the diagram here, this corresponds to the letter A. So this is slightly more proximal to the interarticular hip injection. So here the ultrasound probe will be directed in a more transverse direction, usually parallel to the inguinal ligament. And this is an ultrasound picture that demonstrates the approach for iliopsoas injections. So just to orient you, to the right of the screen is lateral, to the left of the screen is medial. Here you do see our neurovascular bundle, so medial to where the injection target is, you'll see the femoral artery, and your vein and nerve will be in that area as well. The ILP corresponds to the iliopsoas muscle, and this white structure here on the ultrasound, what we call hyperechoic region, is the iliopsoas tendon. So typically the needle's directed in between the tendon here and the bony prominence here, so this is the iliopectineal eminence, or sometimes just adjacent to it. And so the needle is coming from lateral to medial and just adjacent to the iliopsoas tendon here. So some of the common indications for this injection are iliopsoas tendinitis or bursitis, as well as internal snapping hip syndrome. I'll just be going over the first two today, but just so you're aware of what internal snapping hip syndrome corresponds to, this is typically where the iliopsoas tendon is snapping over the underlying bony prominences of the pelvis, so it may be the iliopectineal eminence or the anterior aspect of the femoral head, and so this typically presents with just what it sounds like, snapping of the hip, and it may or may not be painful. And there are two types of snapping hip, internal and external. We'll review external in a moment. So iliopsoas tendinitis and bursitis will typically present with gradual onset of anterior hip pain, often worse with flexion, often activity related. And on exam, patients may be tender to palpation over the iliopsoas tendon, may have pain or weakness with resisted hip flexion, and may have a positive stinge field test. Workup here typically starts with X-ray. You may consider an MRI or ultrasound, especially if the patient's not improving with conservative measures. And treatment typically starts with physical therapy, NSAIDs, rest or activity modifications, and injections. Here, when I would consider an injection for these patients is if they're having an inadequate response to physical therapy or, again, too much pain with physical therapy. And for diagnostic purposes, this can be really helpful, especially when the diagnosis is a little unclear. As we've talked about, anterior hip pain can be complex, can often be multifactorial. So I may have patients who actually have both intraarticular and extraarticular anterior hip pain at the same time. So intraarticular might be FAI or a labral tear. Extraarticular anterior hip pain might be some iliopsoas tendinitis. And in practice, I often will do both of these injections. I do separate them by at least 4 weeks if I'm trying to do the injection for both diagnostic and therapeutic purposes. So if it's unclear based on the MRI findings, based on the exam, where the pain is originating from, it can be really helpful to start with either one or the other, and to assess the response to in the patient, and to give them a little bit of time to make sure the medication has time to take effect. And often there can be multiple causes of hip pain, and I really counsel patients that this may alleviate a portion of their pain, but there may still be some residual pain, and that's helpful, just as helpful as if there was complete response, because then we know that there's some pain originating from the hip joint and some pain that may be originating from the hip flexor tendons. So we'll talk a little bit more about timing, but I do separate those out. But in practice, I often will pursue both of these injections if the diagnosis is unclear. Next, we'll talk about greater trochanteric bursa or gluteus medius peritendinous injection. So on the diagram here, this corresponds to letters B and C. And those are just slightly different locations. C is more at the greater trochanter, and B is just a little bit more proximately around the gluteus medius tendon. And this ultrasound picture, again, shows the orientation of the needle. So to the left would be anterior, to the right is posterior. So here I'm located transversely over the greater trochanter, and you have the gluteus maximus muscle here and the gluteus medius muscle, and those the gluteus medius and minimus insert at the greater trochanter, and you have the gluteus maximus and IT band that come over those, and there are a lot of small bursa in between those tendons, and so when we call the greater trochanteric bursa, it's really the subgluteus maximus bursa, and that's the typical injection target for this injection. And so you can see my needle trajectory here would be from posterior to anterior, aiming for that thin dark stripe, and that's the bursa in between the two tendons. So the indications here would be gluteus medius or gluteus minimus tendinitis, greater trochanteric bursitis, or external snapping hip syndrome. So this is the other type of snapping hip. And external snapping hip is typically when the IT band is snapping over the greater trochanter. And that may or may not be painful. So we won't talk too much about that one, but just wanted you to be aware of that diagnosis. So greater trochanteric pain syndrome is really an umbrella term that includes gluteus medius and minimus tendinitis, as well as greater trochanteric bursitis in young patients, and older patients would also include some tendinopathy or partial tearing of those tendons, but I don't typically see that in my pediatric population. So this typically presents with gradual onset of lateral hip pain, which is often activity related, may be worse with prolonged standing or sleeping on the affected side. On exam, patients may be tender to palpation over the greater trochanter, may have pain and or weakness with resisted hip abduction, and may have a positive Ober test for their tight IT bands. Workup would start with an X-ray, and again, you would consider MRI or ultrasound if they're not improving with conservative measures. And treatment typically starts with physical therapy, NSAIDs, rest or activity modifications, and injections. And the indications here for injections are going to be very similar to what we've seen, but again, if they have an inadequate response to PT, for diagnostic purposes, although I do these less often for diagnostic purposes because there are not as many other causes of lateral hip pain, but sometimes for posterolateral hip pain there can be some confounding findings on exam that might be concerning more for proximal hamstring tendinitis or maybe piriformis syndrome. So sometimes it can be helpful for diagnostic purposes, but more so for therapeutic purposes, or if they're in season and you want to maximize non-operative management. So those are the main clinical indications. Now I'd like to go over a little bit about the procedural logistics. So you can counsel your patients about what this might look like if they have questions, and you have a sense of what they might expect when they're seeing me for an injection. So I use ultrasound guidance for these. These are typically in-office procedures. We do use local anesthetic. There's no general anesthesia, and these don't typically require full nerve blocks. It's really just a little bit of local anesthetic. Can be done with aseptic technique, so not true sterile technique like in the operating room. And just duration, typically these are a routine 30-minute visit. The setup takes the longest, so the setup and the injection might be about 15 minutes. The injection time itself is maybe less than 5 minutes, but everything else, preparing, scanning in advance, consenting the patient, et cetera, it really all takes the longest. So in terms of medications used, for local anesthetics, we typically use lidocaine, ropivacaine, less often bupivacaine. These have different onsets of action, so lidocaine is often used because of the shorter onset of action within 30 to 60 seconds, so really helpful for local anesthetic purposes. But if I'm doing the injection for diagnostic purposes, I try to incorporate some ropivacaine because it has a longer duration of action. So if I want the patient to go and test the hip out at home, do something that would typically be painful, and see if it feels better, the ropivacaine can be helpful because it lasts a little bit longer. And then in terms of therapeutic medications, corticosteroids have traditionally been used, although we've been using NSAIDs more recently, so ketorolac injections, and those can both be used intra-articularly and also peritendinously, and those have a lot of benefits, which we'll talk about in a moment. And in terms of corticosteroids, triamcinolone, dexamethasone, betamethasone, and methylprednisolone. Typically, these have a duration of action of about 6 to 12 weeks, but it's really patient dependent, so sometimes shorter, sometimes can be longer, several months, if not longer than that. So what are some of the benefits of these injections? Let's start with ultrasound guidance. Historically, hip injections have been done under fluoroscopy or CT guidance, which have a lot of downsides. So ultrasound guidance is really great because it avoids exposure to radiation and contrast, which are typically used for fluoroscopy and CT. Ultrasound allows better soft tissue visualization and real-time needle visualization. So you can visualize your needle, aiming towards your target, and you can visualize the medication being injected and ensure it's going to the right place, because sometimes your needle can get, as you're starting to inject the medication, can move around, can get pushed out of these tighter spaces, especially bursa, as they get filled with fluid, get more full, and so the pressure can push the needle out, so you ensure that you're staying in the right location throughout the duration of the injection. Studies have shown that it results in more accurate needle placement compared to landmark guidance. And some studies have shown that image guidance, such as ultrasound, may be associated with less pain on injection, improved patient satisfaction, and better short-term clinical outcomes when compared to landmark guidance. So some benefits of these injections for diagnostic purposes, as we've talked about, can really be helpful to distinguish between intra-articular and extra-articular causes of hip pain. For example, hip joint versus iliopsoas can be a really helpful tool. The anesthetic has onset of action within a few minutes, as I've mentioned already, and so I typically, if I'm doing the injection for diagnostic purposes, we'll use lidocaine, and we'll do the before and after exam, and I'm looking for at least 50% improvement. I'll also ask the patient to keep a pain diary, because sometimes the pain may not be I may not be able to provoke it on exam. It may be something more dynamic that they feel only during sports or only during certain activities that we cannot reproduce in office. If it's only when they're going upstairs or playing soccer, I may not have access to a treadmill or to a stairwell. So I will also ask them to keep a pain diary and mark down on a daily basis until the next follow-up visit what their pain scores are and where they're feeling the pain, what types of activities exacerbate the pain, so that they can really report back in 2 to 4 weeks how they're doing. It can also be helpful to confirm suspected diagnosis if there is post-procedural pain relief, as I've mentioned, and can also help facilitate pre-surgical planning. And a lot of surgeons find this to be a really helpful tool when deciding whether to proceed with operative intervention. And sometimes we do see things on MRI, for example, labral tears, that may or may not be symptomatic. And so this is also can be very helpful when we see abnormal findings on the MRI to confirm whether those are truly the cause of the patient's pain or just incidental findings, and this happens quite a bit. Other benefits, so for therapeutic purposes, as we've seen, injections can help improve pain or other symptoms, can help improve function, can facilitate physical therapy if it is limited by pain, and can help avoid or delay surgical intervention. So what are some of the risks? So procedural risks, these are things that I counsel all my patients about before every single injection. So infection, quite low, typically cited less than 0.1%, but it certainly is a risk. And when you think about inserting a needle into someone's joint, so the concern is for septic arthritis or soft tissue infections, bleeding, allergic reaction to injectable medications, pain or damage or injury to any soft tissues, vessels, and nerves, but this is really minimized with the risk or with the use of ultrasound. In terms of medication risks, there are some risks associated with all the medications that we use. So for local anesthetic, very rare, but cardiac and CNS side effects with unintentional intravascular injection. So again, minimized with the use of ultrasound, where we can visualize the vessels and ensure that we're not injecting intravascularly, but very rarely this can occur. Chondrocyte toxicity and tenocyte toxicity. So this is really something important to consider, especially in our pediatric population. Important considerations when injecting these local anesthetics, especially intra-articularly, is that there's some research that suggests there is potential chondrocyte toxicity, and so wanting to minimize that, for the long term when thinking about their overall cartilage health. Risks of NSAIDs such as ketorolac. So we've been using this medication more recently because studies do suggest that NSAIDs do not affect the cartilage, synovium, or chondrocyte viability. And so generally, safer profile when compared to corticosteroids. And so we've been using these medications a lot more, especially in younger patients. There are impaired hematologic, gastrointestinal, and renal function. So thinking about your typical NSAID side effects, however, although there's some systemic absorption, much less than if you were taking these medications orally. So it's generally thought to be pretty safe. I do avoid these medications if patients have these underlying conditions, especially renal dysfunction, may come up in pediatric populations or GI concerns, or sometimes I'll have them check with their subspecialist to see if it would be safe to get an intra-articular injection before proceeding if they do have underlying medical conditions, but those are less common in pediatric patients, but definitely something to ask about when counseling about these injections. So thought to have less systemic adverse events rather than oral NSAIDs, but there is also a risk of a post-injection pain flare, but generally a pretty good safety profile when compared to corticosteroids. With corticosteroids, we do see facial flushing, we see soft tissue atrophy and or hypopigmentation. Systemic effects, there are some systemic effects even with injections of corticosteroids, so we counsel about hyperglycemia, hypertension, decreased bone marrow density, and adrenal suppression. There is a risk of tendon rupture, again, so important to counsel patients about this. And then really important consideration with our pediatric or young adult populations is that there's a risk of accelerated cartilage loss, subchondral insufficiency, fractures, more rarely osteonecrosis, and very rarely rapid joint destruction, but thinking about overall cartilage health and chondrotoxicity of corticosteroids, and again, a post-injection pain flare. So these are all important considerations, especially with our pediatric patients. These are the contraindications to corticosteroid injections, absolute and relative, that I do counsel patients about, and just, they're in your syllabus for your reference. And then important to comment on limitations, so potential lack of efficacy. So this is always a possibility that I counsel my patients about. We hope that this will help improve your pain, but perhaps, if we're doing this for diagnostic and therapeutic purposes, we may not be targeting the right etiology of their pain. The medication may not work well for them, or it may, I think the bigger limitation is that it's short-term pain relief for some patients, right? So we say 6 to 12 weeks, it's very variable, patient-dependent. And ultimately, this will not fix their underlying problem if there's an underlying biomechanical and or structural issue. So it can have a lot of benefits, as we've seen, a lot of great indications, but it may not address or fix the underlying problem. And that may be something that either needs to be addressed with physical therapy and potentially surgery. Continuing the case, these are all the indications that we reviewed today that could be potential indications for hip injection in the patient that we saw. And these would all be appropriate, and in some patients they're all appropriate, and sometimes they're more patient-specific. But we kind of went through all of these, so I don't think we need to go through them again in more detail. But these would all be reasons to consider injections, and that you could always refer patients to a sports medicine specialist to discuss if you think your patient may benefit from an injection. Thanks so much for your time.